here today, not so excited to be right here. All of us know that Larry loves a chance to be unconventional and eclectic, and it's demonstrated by the fact that I'm here now. However, I do have a different point of view and a few things that I'd like to interject into this conversation about health. First, oh good, that's up there. First, I want to tell you a little bit about myself and how I came to be here. Next, I want to very briefly talk about the historical role of doctors and how it's changed. Then I want to talk a little bit about patients and health. And finally, I want to bring the discussion back around again to doctors and some of the newer parts of medical education and some of the challenges that we face today. So, I was trained, let me push this. I was trained as a physician scientist and did a fellowship in hematology oncology with the intent to have a career in academic medicine. Circumstances changed and I left both science research and patient care, spending about 20 years on the other side, a careful observer of what it meant to be a patient myself and what it meant for my family, friends, and neighbors. Obviously, over this period, there was a fundamental shift in the practice of medicine, as well as profound technological and therapeutic advances. When ready to return to medicine, I was drawn to where I think, and most people think we need it most, primary care medicine. Needless to say, I did emerge into a world very different from the one I left. So the thoughts I share today are simple and completely unoriginal. They stem from conversations I had with Larry about, he used the term this morning, and it reminded me that he said last year's symposium dumped on doctors, and might have suggested a scenario where biotechnology would put doctors out of business. An interesting mix of bravado with some of the prevalent undertones that doctors are a necessary evil, only for now. It made me think a lot about what a doctor is becoming, and should be. So I'm here now not as a thought leader, and certainly not as an expert, but as a placeholder for the ideal of a physician-provider who hopes to continue to provide true value in the changing experience of healthcare. Before I continue, I just have to take the opportunity to thank Dr. Mac Lipkin, the founder and head of the primary care program at NYU, for his mentorship and allowing me to sort of come back in and do primary care medicine, and for the whole division for teaching me everything I know now. Now I see patients at the outpatient clinic affiliated with Bellevue Hospital in New York City, and I also participate in the collaboration of teaching first and second year medical students what we call the principles of medicine. That includes the skills of patient interviewing and patient encounter, along with physical examination, bedside diagnosis, and differential diagnosis. Skip that slide. So I want to start by giving you a really quick historical role of the MD. So throughout history, societies adopted a set of medical beliefs to explain birth, disease and cure, and death. The most elementary belief systems attributed sickness to ill will, malevolent spirits, sorcery, witchcraft, divine or diabolical intervention. The rise of scientific medicine has replaced these ideas for the most part, although these thoughts still prevail in some pre-literate and tribal communities, and unfortunately, even in some corners of the legislative bodies in the United States. Ancient cultures developed a robust medical tradition. The concepts of diagnosis, prognosis, physical exam, and medical prescriptions, largely in the form of herbals, were developed. Transcendental explanations were replaced by the position that there was a natural basis for disease and healing. Great attention was paid to health maintenance through regulation of diet, exercise, hygiene, and lifestyle. So before they had all this expertise in anatomy and physiology, and without an artillery of cures and surgeries, the ability to advance diagnoses and prognoses was highly valued, and an intimate one-on-one doctor-patient relationship was fostered. This personal tradition of bedside medicine was gradually supplanted in Europe by a more scientific mode of medicine based on precise and systematic investigation of anatomy and physiology, epitomized by the dissection techniques that became central to medical education. Excuse me. Medicine was revolutionized in the 19th century by advances in chemistry, lab technique, and equipment, forming the basis for the basic science disciplines that made until recently the basis of the first 2 years of medical school. As a result of technological breakthroughs in the 20th century, clinical medicine grew as fast as the basic medical sciences did in the 19th century. Antibiotics, X-rays, advanced surgical techniques were developed. Specialization became the norm to deal with the enormous volume of advanced knowledge. And before we knew it, teams of doctors were taking care of us. So now, who keeps us healthy? Over the centuries, the responsibility for keeping individuals healthy drifted away from the individual themselves, through using lifestyle, character, and behavior modifications on the advice of your own personal physician. And as medicine grew to depend on specialized drugs and medical procedures, the responsibility for health instead collected in physicians, not just yours, but groups of physicians that you never even met, hospitals, pharmaceutical manufacturers, insurers, policymakers, and other partners who supported them. Scientific knowledge is piling up faster than most of us can assimilate it. On the other hand, major chronic disorders persist throughout the world, and there's little sign that basic health problems in the world are diminishing. This dilemma represents the key paradox in the history of medicine. This unresolved disequilibrium between these remarkable capacities of an increasingly powerful science-based biomedical tradition, and on the other hand, these widening, unfulfilled health requirements of our societies that are variously either economically impoverished and or politically mismanaged societies. So let's look at the modern doctor. Some of you know. So for those of you who are too young or who are TV illiterate, this is Marcus Welby, MD, and his partner. There was a TV series by that name that ran for about 6 years in the 1970s, and he was an absolutely perfect, wonderful, I think he was a GP. And I think this was probably the last time that a doctor was portrayed in film or television without a glaring negative stereotype. It used to be that medical access, knowledge, and literature were confined to doctors. Patients relied on their physicians to supply a differential diagnosis, the explanation of the condition, and trusted their doctor to access any and all plans for treatment regimens. Clearly, there's been a monumental change. For one, and I'm not a seasoned speaker, and I apologize for my amateur slides, but for one, there's an expanding shelf of over-the-counter drugs and tools. It used to be, and not very long ago, that if a woman wanted to find out if she was pregnant, she had to go to the doctor. He'd have to draw blood. He'd have to send it out to an outside lab where they'd see if the rabbit died. They would send the results back to the doctor, not the patient, and the doctor would have to tell the patient the woman whether she was pregnant or not. It used to be, a patient used to be completely dependent on a doctor's office to monitor their blood pressure. I remember when those big machines came into the drugstores and you could go in and measure your blood pressure at a drugstore. And it was, how can we take this out of the hands of doctors? How can you measure your blood pressure without a doctor supervising you? And of course now we can all monitor our blood pressure at home with a $20 machine. And of course, we can now buy more and more drugs over the counter. We don't need doctors' permissions to buy them. Consumers have gained an enormous amount of autonomy. And, of course, we all know what a huge role the internet has played in lowering the barriers to medical knowledge. There's an endless supply of online medical archives, consumer health websites, patient support groups, some of which we'll hear about here. This slide is interesting. I found this. It portrays the source preferences for health information for various age groups in the United States. And according to this survey, if we look at the gold bars, the internet has become the major source of health information. Probably not too surprising. I thought it was pretty interesting, though, that the green bars show that among all age groups, especially the elderly, their preferred source of information would be healthcare providers. So let's shift for a little bit and talk about the patients. Demographics, as we've already heard about today, are shifting the landscape of patient needs. According to the US Census Bureau, the world population doubled in the last 40 years or so. Although the rate is expected to slow, the Bureau estimates the world population will reach 9 billion by 2045. Healthcare systems are already stretched beyond capacity, so how are we going to accommodate a 30% increase? We also have a growing percentage of senior citizens. People over 60 made up just 8% of the population in 1950. In 2010, that percentage increased to 11%, and it's projected to grow from 11% to 22% in 2050. Our country is also experiencing a shift in racial and ethnic makeup. The Hispanic and Asian populations are projected to double. Differences in both cultural beliefs and genetic predispositions have a huge impact on healthcare delivery. Furthermore, globalization, as we've heard, brings endemic disease from all over to our doorstep. Our immigrant populations have spread across the nation, and we all travel. Surviving to older ages affords us the ironic luxury of developing chronic diseases. But in fact, both young and old consumers are developing chronic diseases in record numbers. The insidious nature of chronic disease lies in the fact that one often leads to the other. We all know obesity is on the rise. The World Health Organization predicts there will be 700 million obese citizens by 2015. Obesity then contributes to other chronic diseases such as cardiovascular disease and diabetes. Dick said earlier, and this slide shows the prediction that diabetes will increase by 63% worldwide in the next 20 years, that it'll increase by 27% in high-income countries. And as Larry said this morning, of course, the bottom line in all of this healthcare growth is spending. The US health spending accounted for 16% of our GDP in 2007, higher than anybody else. So the question is, does this spending lead to better health? Among the 30 developed nations that make up the Organization for Economic Cooperation and Development, the United States ranks near the bottom on most measures of health status. Doesn't this seem ridiculous? First, the pathways to better health do not generally depend on health care. Second, even where health care is important, too many Americans don't receive it too late, or receive poor quality health care. Health is influenced by factors in 5 domains: genetics, social circumstances, environmental exposures, behavioral patterns, and health care. When it comes to early deaths, medical care plays a relatively minor role. The greatest opportunity to improve health and reduce premature death lies in personal behavior. This slide shows the number of US deaths from behavioral causes in 2000. Look at the staggering depiction of the effects of smoking, obesity, and alcohol. Take a look at this slide, data compiled by the government initiative known as Healthy People 2010. I think there's a 2050 or something out now. As desperate as we are to supply adequate health care for all, look where it ranks among leading health indicators aimed at improving the health of our nation. Clinicians may question whether behavior is susceptible to change or whether attempts to change behavior lie outside the province of traditional medical care. But for now, they're a major focus of healthcare providers. Improving public health at this point is more likely to come from behavior change than technological innovation. Doctors are and will become instrumental in affecting public policy. Many studies have shown that clinicians can help smokers quit with motivational interviewing and pharmaceutical intervention. Similarly, obesity is the other major preventable cause of death and disability in the USA. Like tobacco use, it's highly prevalent. It usually starts in youth. It's a phenomenon that arose essentially only this century. It's a major risk factor for chronic disease. It's intensively marketed. It's more common in low socioeconomic classes, and it's difficult to treat. Motivating strategies continue to be our best tools. To be successful at improving health and controlling costs, it's imperative that we not just treat chronic conditions, but stem the tide of diseases in the first place. Improving diets, increasing exercise, and stopping smoking are key. The benefits of these changes, again, have the potential to far outweigh any new technology here or on the horizon. Let's take a look at one of my very common patients. He's 45 years old, male. He's way overweight. He has high blood pressure. He has diabetes. He has lipid disease, LDL, greater than 100. And he smokes. Now I'm going to give him lots of drugs. I'll give him a couple for his high blood pressure. I'll give him a couple for his diabetes. I'll give him a statin and maybe more for his lipids. And I'll give him an aspirin for heart protection. But if I could just give him one thing, or if he could decide to just do one thing or take one thing, it would be to stop smoking. Biomarkers of the future certainly do have potential to improve our health, but it's important to remember that we already have some potent disease indicators, and they're not doing as good a job at keeping us healthy as we would like. Let's look at the biggies. We can measure blood pressure, and we have a target for healthy blood pressure. We can measure lipid levels, and we do have healthy targets for lipid control. We have a simple blood test that measures impaired glucose metabolism in diabetes. This slide illustrates that within the US population of diabetics, only about half have their glucose, cholesterol, and blood pressure under control. This must be due to a confounding interplay between access to healthcare services, inadequate healthcare delivery, and patient resistance to appropriate interventions. Along with the trend toward patient empowerment comes a responsibility to maintain the partnership or teamwork between the patient and the doctor. No matter what advances medical science makes, value will not increase unless patients follow treatment guidelines. While the quality of medicines is important, how they are used or not used is more important. Study after study shows that about half of people with chronic medical conditions do not adhere to their medical therapies and regimens. So a huge burden of responsibility falls upon an effective clinician to be a successful educator, motivator, and monitor. Let's go back to patients for a minute. We know that this country has become increasingly polarized socioeconomically, and this is nowhere more evident in healthcare. We, the people in this room, generally don't have such a big problem. Most of us are educated, affluent, well-connected. We get our health. We have health insurance. We have the best doctors that our extensive network of elite contacts can tell us about. We're not too fat. We don't smoke. We all have gym memberships. We have jobs that allow us time to exercise. We have help with our housekeeping chores that gives us more time to exercise and, moreover, relax. We have support systems and we have psychotherapists to help us deal with our stress. Let me tell you about my patients. Many of them are Hispanic. They've grown up in a culture with lots of food, and they have had very little education. They're new to this country. Many of them are illegal. Of course, they don't have insurance. They're unemployed, or they have precarious employment or low-level employment. Sometimes they get Medicaid, but then they get on and off and back and forth, and it's impossible. They generally are involved in manual labor. They spend long, long hours either standing all day in a bodega or lifting boxes in a factory or sitting in a truck driving the things that we need all over the place. The women do all of their own housework, and they do the housework for us too. They have a ton of stress. They have so many somatic complaints like low back pain and gastrointestinal distress. And that's what they're most concerned about. And that's what they come to see us about, despite the fact that they have these multiple chronic diseases, obesity, hypertension, diabetes. They end up getting a boatload of medications for us for things that that don't bother them. We can't fix their low back pain and GI distress. And we're handing them all these medicines for their diabetes and high blood pressure, and they don't get it. Their lives are unstable. Their circumstances change. They lose their jobs. Their kids get in trouble, and they don't have the resources to get them out of trouble. They can't keep their appointments. They're not their own bosses. The work changes, and their boss tells them they can't go. I have a lot of Chinese patients, too. Their language is even more of a problem for them, even though we have fancy telephone interpreting systems. They're immigrants, lots of them illegal. They have a completely different culture and a system of alternative medicine. They present with endemic diseases like hepatitis B. Again, they work really, really hard in Chinese restaurants all over this country. never getting time off, so they have very little time to come visit a doctor. Some of them, we have patients coming into New York on the bus from Ohio on their day off. They come out, they ride all night, they come and sit in our clinic for hours, and they go back the same night because they can, if they're illegal, we don't ask any questions and we treat them, but we have to do everything that we can possibly do for them in that one visit because they'll never be able to come back. So we have to remember that we have a large and growing population of patients that I would call anything but empowered. So let's shift back to doctors again, sorry, and look at their education. Where are my slides? The faithful see a day when a small amount of a patient's fluid or tissue can yield comparative biomedical clinical data analyzed with genomics, proteomics, metabolomics, and other emerging disciplines. As we've talked about many times already today, what we do with all that information available to us will be an even bigger challenge. Our medical records are already replete with information. Integrating that data and constructing predictive models will require a strong quantitative discipline that'll take the practice of medicine to a different level, although I think doctors can and should do it. Doctors are getting more sophisticated training in epidemiology and statistical analysis. There was a time when 4 years of lecture-based instruction produced new physicians with a knowledge base that would carry them through a lifetime of practice. But obviously now the amount of medical knowledge continues to expand, and it's increasingly difficult to provide learners with all the information they need to take care of patients. So the new curricula is aimed at fostering lifelong learning in our doctors. Students spend much less time in lectures and instead spend more time reviewing literature and discussing it in smaller groups. The mission is to enable them to access all of this information you are producing and to critically appraise it. And again, they are going to need to be able to use it. I made a note about Steve depicting the trial attorney as the low man on the totem pole that had to distill the information for the jury. I kind of think that that's what doctors do. We are teachers in every sense of the word, and if you're lucky enough to have a doctor that you trust, you go to him or her to help you distill the wonderful information that you get from all the other sources that we can go to now, and sit down and talk about it and distill it and help to make a good decision. Courses like clinical epidemiology and medical decision-making, clinical appraisal, foundations of medicine, psychosocial block, the things that I'm teaching today were unheard of in my day. We can't stress enough that there's more to being a good doctor than being able to make an accurate diagnosis or design an effective treatment plan. Studies have shown that that patients want their physicians to be confident, empathetic, humane, personal, forthright, respectful, and thorough. Newer coursework really is specifically designed to give medical students the opportunity to develop interpersonal skills that promote excellent patient care. Focusing on the humanistic side of medicine reinforces the idea that there's more to being a good doctor than science. People's experiences of health care provided by the health system are determined first and foremost by the way they're treated. People want to know that their doctor understands them, their values, their family's values, and their life's experience. But it's not easy to be a doctor today. It's one thing to teach the foundations of basic medical practice to our student doctors, but we have to be careful they don't lose it once they get out into the real world. I think we could use a Somamer chip that could predict ideal doctors. There was a great article by the wonderful doctor and writer, I don't know if you guys know him, named Abraham Verghese in the New York Times last February 26th. And in it, he notes that, and we all know that any of us could walk down the halls of a hospital ward only to see one computer after the other with humans, doctors, nurses, everybody glued to them, quote, like piglets at a sow's teats, unquote. There is obviously no doubt that computers have been an invaluable resource in patient care. But the complaints that I have personally and that I hear from my patients' families and friends are rarely about the lack of technology. Quite the contrary, it's about the excesses. My own experience in hospitals and even in doctors' offices galvanized me to promote the case for better patient bedside care. Nurses and doctors come in to visit the computer monitors, often without even acknowledging or looking at the patient. At best, they throw questions in the air while typing on their computer. Verghese's coined a term for the computer record generated by such encounters. He calls it the eye patient. It threatens to become the focus of our attention, and real patients feel neglected. My other pet peeve about emergency rooms and elsewhere in the healthcare system is the ease with which we order tests. The availability of CAT scans has caused most doctors' physical examination skills to atrophy. It's easier to order a CT scan to see whether someone has fluid in their lungs than to go over and actually examine them. So even though we're still teaching medical students to do this, we have to remain vigilant to maintain our bedside skills, because the truth is we do miss things when we don't examine the body. Moreover, and this is it's a ritual that remains important to most patients. It establishes a connection, a therapeutic relationship, a human bond, just to put your hand on the patient. Patients are very savvy. They're quick to perceive when they're given the short shrift. Conversely, they are enormously appreciative when they are not. It's all about cementing this doctor-patient relationship, making a commitment to be with a patient, to see them through, if it's only that one encounter or through years of sickness and health. But it is really, really hard to be a good doctor these days. And the real problem is that doctors do not get paid to talk to their patients. Dr. Stroke is emblematic of a transformation in American medicine. Here he is examining his patient at 10 a.m., and he's already got patients backed up in the waiting room. Too many stories, too little time. The centuries-old intimacy between the doctor and the patient is being lost. Younger doctors want better lifestyles, shorter days, free weekends, no emergencies, larger practices, trade away Dr. Stroke's intimacy for more services and arguably better care. Patients, and I found this interesting, that patients and doctors both complain that appointments are rushed, but actually the time that doctors spend with each patient, on average 16 to 20 minutes, has remained unchanged for years. Instead, patients have gotten sicker and treatments have gotten more complex. As we've talked about, half of all Americans have a chronic disease, like high blood pressure or diabetes. 25% have two or more. The increasing rush through a blizzard of questions and tests and referrals leaves little time for the intimate chit-chat that most doctors and patients alike yearn for. Dr. Stroke has an affluent practice and has made a nice living. But changes in payment structure, which I won't go into and can't begin to understand, have changed his income drastically and left him embittered. He breaks even at 3 visits an hour and needs a 4th to turn a profit. It's the same problem everywhere, including the clinic I work at. The doctors there are dedicated to all the best principles of state-of-the-art evidence-based medicine. We have a very sick, needy population of underserved patients who we're very happy to talk to and listen to. But the reality is that doctors are mandated to see 4 patients an hour. You can imagine that this has the doctors angry and frustrated. We can't possibly do right by our patients. We can barely address the myriad of issues, perform abbreviated exams, write prescriptions, write referrals, attend to their acute problems, and address all the appropriate health protection matters that are so important in just 15 minutes. It's debilitating, it's frustrating, it's unfulfilling, it's not what we set out to do as doctors. We don't like giving less than optimal care. It leads to burnout, it leads to controversial issues like concierge medicine. So I'm going to stop here. I hope that I've added another dimension to our conversation about healthcare. I think too often doctors are seen as part of the problem. Obviously, some of them are. I hope I didn't seem too much like I was just trying to defend doctors, but I think if we put undue blame on them, we risk missing the real problems and solutions. I think doctors are trying to do a better job. Obviously, this is a broken system for everyone. We need more primary care doctors, that's my plug, and we need to find a way to let them do their jobs. Only then will we make the progress towards using the powers of medical and scientific innovation to create better health. Thank you.
Thank you for a heartfelt talk. Some questions?
Ruth, you did a wonderful job at grounding the whole day's discussion, bringing it down to the doctor-patient relationship. Great. So as someone who has thought more than I or most people here about the role of the empowered patient and the changing role of the doctor-patient relationship, I'm wondering what you think about direct-to-consumer advertising of drug products, especially as television.
Is that me?
It was, but
Do you think it's helping things, hurting things, driving your patients crazy, informing them more?
Yeah, probably, what did I do? All of the above. I mean, it wasn't so long ago, right? That, I mean, we remember when there was no advertising allowed in magazines, on television, and I mean, would we ever have imagined that we would be seeing commercials for Viagra on primetime television? It does all of the above, I think. In my patient population, obviously, they're not terribly literate, and they don't come in with having read a lot about medications. But yes, certainly, there are many over-informed people, and there's a lot of misinformation in addition to all the good information that's out there.
other questions? Here. Sorry, 1 second. Here comes the microphone.
Thank you, Dr. Crowe, Ruth. I was just wondering if you would like to share any of your experiences, or if you had an experience that deals with kind of like integrative medicine or holistic medicine or alternative medicine, how it may have been helpful or beneficiary in your practice. I know there's a severe shortage of primary care doctors now because there's not a lot of money in it, but it seems like integrative medicine should maybe really start at the primary care level. So thank you.
I'm not even sure what you mean by integrate. You mean incorporating alternative medicine therapies?
Complementary. Mm-hmm. Yeah, thank you.
Sure. I mean, I don't know why any doctor would object to being open to that. And there's been a lot of experimentation done on that. They've tried, at NYU, they've tried bringing hypnosis into and acupuncture into the surgical suites and things like that. I don't think they've gone that well, but certainly, I mean, especially in with my patients, I have an enormous number of Chinese patients, and they all participate in alternative medicines. And we try once we get used to seeing the cupping marks and all the tapes and things all over them, we obviously encourage them. But it makes it very difficult to be good teachers because if we don't I wish I knew more about them, because it's hard to incorporate them into the traditional medical principles that we try to teach them in terms of health protection.
Last question?
So you told us that the most important things were behavior change and relationship, patient relationship with the healthcare system. Why do doctors have to do that? And why does it have to be the elite that get into medical schools? How can we open the sluices in such a way that we can help people change their behaviors and feel like they have a better relationship without requiring $500,000 worth of education to do that?
Yeah, that's a good question. And, doctors would obviously say, a lot of doctors would prefer not to have to do it. I don't have an answer. I'm not an expert or a thought leader. I'm just putting the questions out there. Yeah, it's why. I mean, there have been, the public health initiatives have worked. Seatbelt use, helmet use, cigarette smoking is way down.
Do you have nurse practitioners?
You have to yell into it, Larry. It's on. It's on. Just point it directly towards you.
So do you use in your clinic nurse practitioners in
Yes.
an important way?
Oh, what am I doing with this? Absolutely. We have to see 4 patients an hour. We definitely rely on nurse practitioners, patient care associates, nurses to pass off all kinds of patient education and referral tasks enormously, not to mention the incredible job they do translating and
All right, well, thank you very much.